another kind of experimental trial happened in China that is, combined with the chemotherapy and the immune checkpoint block therapy, like a anti-PD-1 antibody combined together. And clinical trials in the phase 2, one-arm trial that happened in the Zhongshan Hospital. So Professor Si, probably you have something to report.
Respected Professor Colombo and Professor Stefano and Professor Van and Professor Cao. Nice to meet you, everyone. It's a great honor to participate in the discussion on the progress in the treatment of advanced cholangiocarcinoma. We all know cholangiocarcinoma is a deadly malignant tumor, and surgical resection is the best option. Unfortunately, tumor recurrence after surgery is frequent in patients with high level of CA99, large tumor or multiple tumors, lymph node metastasis or nerve invasion. Thus, the overall survival after resection is very poor. Adjuvant treatment strategy has been to use the improve the dismal prognosis of cholangiocarcinoma patients after operation. Based the results from the phase 3 BioCapa trial, carbitabine could extend the OS of the resected cholangiocarcinoma. So carbitabine has become the preferred adjuvant chemotherapy in patients with resected cholangiocarcinoma. However, GMOX did not improve the OS of the resected cholangiocarcinoma. In addition, several adjuvant strategies are being evaluated in patients with resected cholangiocarcinoma, including in our center. So in clinical centers of cholangiocarcinoma, we routinely use carbitabine to prevent from the recurrence for cholangiocarcinoma patients with the high risk factor of recurrence. Our center, Professor Jia Fan and Jianzhou teams also elevated the survival benefit of the PD-1 inhibitor tolipuli and target therapy lenvatinib in combination with GMOX chemotherapy as the first line treatment of advanced and unresectable ICC. We enrolled 30 pathologically confirmed advanced ICC patients at Zhongshan Hospital. The significantly associated with the PD-L1 expression and DDR related mutation in tumor samples. Until last month, median PFS was 10 months and median DOR was 9.8 months, and median OS has not been reached. It may be more than 18 months. Therefore, the combination of tolipuli lenvatinib with GMOX chemotherapy was the terrible and show promising OR in patients with advanced ICC. Certainly, this finding warrant further study in a large randomized trial.
If I understood correctly, there are good and very encouraging outcomes in a very preliminary study of a combination therapy, correct, between IOs and usual chemo. My understanding was that IOs had to be potentiated with the vascular factor inhibitors like, generally speaking, TKI. How do you explain such a favorable outcome of a combination between IO and ordinary chemotherapy? Perhaps Professor Cascino is the right person who can elaborate on this.
That's great. How about Professor Cascino?
Yes, and I think that is very, very interesting data. I think that the combination of an IOS and lenvatinib, mainly lenvatinib, not probably other TKIs, but lenvatinib may play a role in the combination with immunocheckpoint, because probably lenvatinib may be able to prevent the arrival of tumor-associated macrophage into the tumors, and this may change the microenvironment of the tumors, making effective IOs that otherwise are ineffective in these tumors. And my question is, really do we need to combine to lenvatinib and IOs, even chemotherapy? And probably at the beginning of this history, I was convinced that probably we don't. But really now, I think that probably data from this trial, the professor suggested that probably we can combine safely chemotherapy and lenvatinib and IOs, but not only safely, but probably even more active, because once again, chemotherapy may play a role in killing the tumor cells, of course, but even by modifying in some way the microenvironment. I remember that oxaliplatin may influence the angiogenesis of the tumors not in a favorable way, because it increases angiogenesis, but lenvatinib may prevent this increasing. So far, maybe we combine the effect or the counter effect of lenvatinib and chemotherapy, may favoring the action of chemotherapy and probably IOs. So I think there is a strong rationale for the combination of chemotherapy and lenvatinib and IOs, and I think above all lenvatinib and IOs. And I'm very curious about the final result of this trial, and if we are interested in to go to a phase 3 trial, in a larger phase 3 trial, because unfortunately in Italy we can use this combination, and there is no interest by the company to design and to plan a clinical trial now in Europe, for instance, in cholangiocarcinoma. You know, probably that in gastric cancer, there is a trial running about this, but it's very, very difficult. It's really a challenge to convince the company to move to cholangiocarcinoma or even to pancreatic cancer, because more or less are quite similar. And I'm very interested to know your results.
Although some studies have reported for focus schedule can be used as a second line therapy for cholangiocarcinoma after failure of GC or GMOG stem cell therapy. Recent studies have reported promising results of the combination of lenvatinib with the PD-1 antibody in several tumors, including HCC. In 2018, ASCO Professor Zhao in China also reported the efficiency of the lenvatinib plus the PD-1 antibody for the treatment of 14 patients with ICC. The ORR was 21%, and the DCR was 93%. In 2019, last year, ISMO Professor Zhao also reported the results lenvatinib plus PD-1 antibody as the second line therapy of 60 patients with BTC. The ORR was 30%, and the median OS was 11 months. So we also exit the efficiency of lenvatinib plus PD-1 antibody tolerably as the first line treatment of the 30 patients with ICC. The trial is ongoing. Yeah, we anticipate we can get the good results in the future. Yeah.
That's great. That's great. Thank you. Thank you, Professor Cassino and the Professor Colombo for the nice interpretation. Okay, the next question is probably presented by Professor Li Nan. And please, if you have some kind of questions too for the open for the discuss.
Thank you, Professor Cao. Thank you, Professor Colombo. Dear Professor Colombo, I'm honored to discuss with you about the research of cholangiocarcinoma. Now, many target drugs for cholangiocarcinoma are undergoing clinical trials, but there is no targeted drugs that has the same standard as lymphadenine in HCC patients. For this unresectable and relapsed CCA patients, which targeted drugs is your first choice? Thank you, Colombo.
I'm very sorry not to have understood completely the question. Can you repeat it louder, because it's hard for me.
Okay. For the unresectable and or relapsed cholangiocarcinoma patients with targeted drugs is your first choice.
Okay, I'm sorry to say this is up to the clinical oncologist. Professor Cassino is the master in this. He is the one.
Thank you.
I told you, I'm a clinical hepatologist. I'm not.
It is a good answer. It is a good answer for a pathologist.
Yeah, but what I can do?
No, I know. No, I thanks for this question because it's really relevant. And I agree that there is a great difference between hepatocellular carcinoma and cholangiocarcinoma, because if you use sorafenib, lenvatinib, you observe an effect. You can discuss, or if you have some consent by the magnitude of the effect, but you can find an effect. It's completely different, at least in my mind, until now, in cholangiocarcinoma. And I think that probably we have to consider that we can use biological agent for all the patients, but we have to detect the mutations, and we have detected the mutation, we could use the specific agent. And I agree with you that probably this is the future of this patient. And I wonder, for instance, if I have ADH1 and ADH2 mutation, probably ivosidenib may be a chance for them, for this patient. Of course, this represents more or less 20% of the patient, and this is a trivial number of the patient hosting this mutation. So I think that may be an opportunity. The strange and the disappointing for us is that we can use these drugs because our authorities have not approved, at least until now, and probably even for the next future, these agents. So we know that the patient have this mutation, and unless you can enroll them in a clinical trial, this patient may not benefit from this approach. Or for instance, for FGF receptor 2, we can use pemigatinib, and there is an expanded access program in Italy, and fortunately this patient may benefit from this approach, even if probably these fusions are not more than 10%. But once again, I think that your question is a crucial point for the development of new attitude to treat this patient for metastatic or locally advanced disease. We needed to know the mutation profiling of this patient, and according to this, we can choose the best biological agent for each of these patients hosting a specific mutation. And I think this is the challenge for all of us in the future to design personal tailored treatment or personal medicine. I think that is a key point in order to improve the outcome of this patient.
Thank you.
Sorry, I just want to put a question to Stefano. Stefano, I understand that precision medicine will take care of 30% of the overall unresectable carcinomas with a special reference to the intrahepatic. What to do for the other ones? So we are still left to the, standard chemotherapy.
Yes, unfortunately, I will say yes, because in reality we know that with chemotherapy, I am really envious of the possibility of our Chinese colleague to use lenvatinib, immunotherapy, and GEMOX. I would like to use this, but unfortunately I can't. But I think that this is a way. Unfortunately, because chemotherapy may offer some benefit to this patient, but probably the most frustrating aspect of this treatment is not that is not able to determine a response, but the duration of response, the duration of tumor control is really short. And after a few months, the patient progresses again. And in this case, we are not able really to offer an effective second-line treatment in terms of chemotherapy. And this is why I think is eagerly awaited the possibility to treat this patient with a biological agent.
Okay, great. So this is a very, very nice talk. And thank you, Professor Cassini and Professor Column. And any others? So I think the next question, Professor Xinyong Yang, can you present your own questions? And we might open the discuss in this panel.
Okay, nice to meet you, and thanks for Chairman Professor Chow, and nice to meet you, Casino and Crumble. Since I'm a surgeon, I want to ask some question about the ICC treatment, about the medicine. So since as you mentioned in the articles in the review, so several type treatment such as chemotherapy, such as targeted therapy, and checkmate inhibitors used for the ICC treatment. And could you tell me for this treatment who would be benefit for this treatment, such as chemotherapy, such as PD-1 treatment, and also target therapy? This is the first question. And the second question, since it is difficult for the clinician to evaluate the treatment response after this systemic treatment, I think maybe since maybe we can use imaging evaluation, also tumor biomarker, but I think most such as CA199 is only about 40% maybe, so could you tell me something about the secreting tumor DNA in the evaluation, the treatment response? And also maybe you can talk about something about this as a biomarker for select the treatment, the drug, how to select the drug, maybe some in the ICC treatment. Thank you.
Thank you for your question. Let me just answer myself the very last ones, because is where I have my personal expertise. Going through the literature, I realized that there is still the position that was elaborated by the Americans regarding, C19.9. When it reaches 1,000 international units, it's very much predictive of extrahepatic CCA. But I must say that the best records of sensitivity are bound to the use of combined scores, where you pull C19.9 with classical enzymes and others. My understanding is that there has been a step forward in the imaging techniques where expert radiologists are able with DWI to solve doubtful diagnosis of imaging, and more recently also in the staging using echo ultrasound guided scrutiny of the domain of the area. And at this point also, I have recently reviewed a paper published in Hepatology that deals actually with the staging, using staging lymph nodes in CCA, mostly proximal CCAs, using a combined technique of echo-guided ultrasonography followed by fine needle aspiration. And then I leave, of course, the chemotherapy PD-1 question to Professor Cascino, who is the real expert. But I want to put a question specific to all the panel of the surgeons who are attending this meeting. There are two questions that, in my opinion, requires an answer, at least to us Western hepatology. First, what is the real association of primary sclerosing cholangitis with the proximal CCA? And second, whether or not you are using echo-guided fine needle aspiration. So, I mean, endoscopic echo-guided fine needle aspiration for staging lymph nodes in cholangio, particularly, I understand, proximal, to improve staging. So I leave to Professor Cascino, of course, who is the expert, to answer your interesting question of what to use between chemo and PD-1 and the rest. Stefano?
Yes. No, thanks for this question, and thanks for the opportunity to admire the skyline of Shanghai, I suppose, if I recognize. This is very, I was there only just on time, but I remember. No, I think that probably it could be the future of treatment. And I think the combination of toripalimab, in your experience, and lenvatinib may be really useful to, in some way, to not select the patient candidate to receive immunotherapy, because I think that the lenvatinib may be able to overcome resistance to immunotherapy, by modifying the microenvironment. And I think very, very impressive results in terms of response rate, and not only in terms of survival, PFS, but I think that if you observe a response rate about 80%, I think that it could change completely the neoadjuvant approach for these tumors. I think that may open completely a change in the treatment. You have not to operate on immediately this patient, but you have to treat it with this combination, because if you confirm that the response rate is so really high, probably all the patients should receive this treatment before operation. I know that surgeon probably could be not completely agree with me, but I think that when we observe a response rate of 80%, we said, oh, this is really great result in terms of two things promising. In order to obtain a radical resection without no positive margins, this is a negative prognostic factor. And probably you can be able in multifocal tumors, most of these patients may be candidate to receive surgery after treatment, whereas before they can't. So I think the change, even the number of the patient candidate to resection, if you can obtain really is a huge response rate. I know that this is a explorative trial, this is a preliminary trials, but the results are really impressive, and we're very convinced that this is the way to follow if we want to improve the patient, not only in the metastatic setting, but even in the neoadjuvant and probably in adjuvant treatment. It could change completely the approach for this patient. I'd like to congratulate with this experience, because I think that is maybe relevant for the future in order to design new clinical trials.
Okay, great, thanks. That's a very nice talk. So, thank you, folks.